Rules, U.S. Department of Veterans Affairs. Before we begin, I'd like to mention a few logistical items. You can download a copy of today's presentation from the CAQH.org website. To do so, navigate to the core pull-down menu at the top of the CAQH.org welcome screen and select the Core Education Events page. A link to the PDF version of the presentation can be found under the listing for today's webinar. On this slide, you can see a screenshot of the attendee GoToWebinar dashboard. You should see something that looks similar to this on the right side of your computer desktop. When joining today's session, it's possible you may have joined the audio portion of the webinar using your computer speakers by default. If possible, we would prefer you to join the webinar audio by telephone. To do this, please select the telephone audio button at the audio panel of your dashboard, and the dial-in information will be displayed. Make sure you enter your audio PIN, which is found under your dial-in information. We will save time at the end of today's program dedicated to responding to the audience questions. You're encouraged to submit your questions at any time during this webinar by typing them into the questions panel of your dashboard. We ask that you please submit your when you submit your questions, you please identify your type of organization so we can give you a more accurate response. We'd like to thank today's guest speakers from the U.S. Department of Veterans Affairs, Dr. Ruth Ann Phelps, Director, E-Business Solutions, Katie Knapp, Program Analyst, Industry Liaison, and Susan Kirsten, Project Manager, E-Payments Project. Today we will start off with two presentations from our CAQH Core staff. First, an update on the CAQH Core Phase 4 operating rules, which were recently approved, and then an overview of the CAQH Core Phase 3 operating rules on EFT and ERA. That will be followed by a case study presentation from the largest integrated healthcare system in the United States, the Department of Veterans Affairs. We're delighted to have 3 VA speakers who will be sharing their Phase 3 implementation experience. But before we begin, CAQH Core Senior Associate Drew Boytel will walk us through our first polling question. Drew?
Thank you very much, Jessica. So this will be our first of 3 polling questions that we have throughout the webinar. And I will read the question, and then I will launch the poll. And then on your screen, you'll be able to answer directly. And after a few seconds from responding, I will share the results. So this first question is, please indicate the extent to which your organization sends or receives healthcare payments through EFT. And this is the ACH network only. So I will launch the poll. Please stand by. And you should see it coming up on your screen. And we will pause here for about 15 seconds for you all to respond. We'll wait about 10 more seconds. All right, I will close the poll and share the results. So it seems as though 36% of you have said above 75% of the time, and the second largest, 26%, 51 to 75% of the time. So that's good to see. And so we will carry on with the rest of the program. And so next, I will introduce Erin Richter-Weber. She is the Core Senior Manager, and she will begin today's program with a presentation on the operating rules from CAQH Core. Erin?
Thanks, Drew. Before we launch into the discussion on the VA's experience with the Phase 3 operating rules, I want to give a quick update on the Phase 4 operating rules. Many of you are probably aware we spent the better part of this year and part of 2014 as well developing a new set of Phase 4 operating rules. The slide you're seeing now gives a high-level overview of the scope of requirements included in the Phase 4 rules. There are 5 operating rules included in Phase 4, including 4 infrastructure rules which build on the existing core infrastructure rules and apply to the 4 transactions: prior authorization, claims, enrollment, disenrollment in the health plan, and premium payment. So the requirements within those infrastructure rules are very similar to the infrastructure requirements you may already be familiar with in previous phases of core rules. We have processing mode requirements, acknowledgement requirements, system availability and companion guide requirements, etc. Additionally, there is a fifth rule, and that is a connectivity rule. And that is, contains a new set of connectivity requirements which apply to these 4 transactions as well. On the next slide, we give a little bit of an overview on the impact these Phase 4 operating rules are intended to have. We talked a lot about more system availability, acknowledgments, response time, and how these will increase consistency and automation across entities, identifying gaps and barriers better at various points within the transaction exchange, reducing administrative costs. Staff will spend less time on the phone as we use these electronic transactions more with enhanced infrastructure and connectivity. And finally, providers should see enhanced revenue cycle management resulting in improved cash flow. A little bit about the process behind the development of the Phase 4 operating rules on this slide. I'm first going to talk about the process from the core perspective and what the CAQH core participants did to develop the rules, and then talk about next steps with regards to any potential federal mandates related to these rules per Section 1104 of the Affordable Care Act. So with all of the core operating rules, the core participants start by voting in our various subgroups and work groups and discussing and debating the rule requirements and ultimately then the text of the rules. I think we conducted 15 or so straw polls at this level. The next step is formal voting by CAQH core participating organizations. And these are those organizations that will ultimately have to implement the rules, those organizations creating, transmitting, or using the transactions. We're thrilled to say that at this level, we had a 90% participation rate in the vote amongst the core participants, and 88% of those entities approved the Phase 4 operating rules. The final step in the process is a review by the core board, which unanimously approved the Phase 4 operating rules. So that process is complete now, and we move on to what the federal process is, and that's laid out in 5 steps on the right hand of the slide. Step 1, CORE is going to update NCVHS early next year on the status of the Phase 4 operating rules and the requirements. As appropriate, NCVHS then will make an adoption recommendation to the Secretary of the Department of Health and Human Services. HHS would then publish an interim final rule similar to what we've seen with the previous ACA mandated operating rules. There would be a public comment period then, 60 days or more, where the public can submit comments on the operating rules and the regulation to CMS and HHS. And then step 9, depending on whether or not HHS decides to change the policy based on public comments, the industry would be required to implement the operating rules. And this is typically within 2 years of publication of the regulation. So I skipped ahead a little bit in the animation there, so I'll give you guys a minute to catch up. But these slides also will be available on our website if you want to take a closer look. So there still is opportunity to provide public comment on the Phase 4 operating rules. They are free and available on our website if you want to take a closer look. Slide 10 talks about some of our future activities over the next year. Our focus is going to shift now to supporting Phase 4 implementation. You'll see many of the same tools we've provided in previous phases available for Phase 4, including, of course, certification, but also an analysis and planning guide, a dedicated web page, frequently asked questions, more informational webinars, and other unique tools that will help entities implement these specific rules. And as always, the core staff are available to answer any questions you might have. With that, I'm going to turn it back to Drew to do another polling question.
Great. Thank you very much, Erin. And this brings us to our second polling question in the webinar. I will read it, and then, like last time, I will launch the poll, and we'll pause briefly for you all to log your response. And so this question, please indicate whether your organization intends to voluntarily implement the Phase 4 CAQH core operating rules. I will launch the poll right now, and we will pause for the answers. Please go ahead.
And as we're pausing here, I'm just going to add, when Drew talks about voluntary implementation, entities are free to begin implementing the Phase 4 operating rules now. The requirements are out there. for voluntary implementation, and certification will be available next summer. Once HHS goes through some of the steps we just talked about, then we'll know more about the scope of the mandated operating rules for these 4 transactions.
Great. Thank you, Erin. Just 2 more seconds, and I will close the poll. And now I will share the results. And the majority of those who have answered, 44%, said that they need to learn more, and which is good why we're having these sorts of education sessions, and you can expect to learn more. But as always, please feel free to reach out to us at any time, and we'll share our contact information at the end of the presentation. And with that, Erin will, I believe, introduce our next section.
Great, thanks, Drew. I'm going to talk a little bit about the Phase 3 operating rules before we launch into the VA story, just to do some level setting. I know many of you are probably already very familiar with these requirements. As you can see on slide 13, the APA mandated operating rules have several phases and compliance states. The first set of operating rules for eligibility and claim status were required to be implemented by January 1, 2013. The Phase 3 operating rules for EFT and ERA, that compliance date was January 1, 2014. So at this point, all HIPAA-covered entities should be conducting these transactions using the core operating rules. And we'll talk a little bit more about the requirements in a minute. Coming up, we have the health plan certification through the core certification or the HIPAA credential, which is proposed at this point. This applies to only health plans and includes potential penalties for incomplete certification. So we're still waiting on more information on this process from CMS and HHS in the coming months. And then, of course, the Phase 4 operating rules, or those operating rules mandated for the prior auth claims, enrollment, disenrollment, premium payment transactions, as well as healthcare claim attachments, for which HHS has not addressed the standard yet. At this point, the status is that the Phase 4 operating rules have been approved for voluntary implementation through CAQH Core, but again, we're waiting on more word from CMS, HHS on a implementation date for these rules. The next slide just talks about the status of the EFT standard and the operating rules. So the healthcare EFT is actually a relatively new HIPAA standard. In April of 2013, CMS announced it as a final rule. The standard is the NACHA CCD Plus and the X12 5010 835 Tier 3 TRN segment, and that composes the HIPAA mandated healthcare EFT standard. In terms of who must comply with the standard and operating rules, all HIPAA-covered entities, and this applies not just to Phase 3, but all of the mandated operating rules. Providers are only required to implement the operating rules if they transmit the protected health information electronically, directly, or through a business partner. Also, health plans and healthcare clearinghouses are also considered HIPAA-covered entities. The next slide talks a little bit about the transaction flow between EFT and ERA. The development of these operating rules really was a great example of the convergence of financial services in healthcare and cross-industry collaboration. Both transactions are using recognized HIPAA standards, and the aim is to increase adoption of both of these standards. So I'm not going to go into the details of these standards, but the ERA, of course, is the file that replaces the explanation of benefits payment paper, and includes kind of the receipt of the information or payment from a health plan to a provider. And the EFT is obviously the payment itself, which is transmitted electronically via the ACH network. The next slide is a high-level overview of the EFT and ERA operating rule requirements. Again, these 5 rules are available for free on our website if you want to take a closer look. There are 5 rules, 2 of which address EFT and ERA enrollment data. There's a rule addressing the uniform use of CARCs and MARCs, which are the denial and adjustment codes included in the ERA. There's a reassociation rule that improves a provider's ability to reassociate basically the payment and the receipt, the ERA, received from a health plan so that they can properly conduct their revenue cycle activities. And finally, there's an infrastructure rule similar to the infrastructure requirements we talked about in Phase 4 that applies to the 835 transaction as well. The next slide summarizes some of the benefits of the EFT and ERA operating rules. Enrollment data set rules result in a standardized electronic enrollment for providers. So they can enroll with all health plans using a consistent set of data elements. They're not getting asked different questions from different organizations. With the health plans consistently using denial and adjustment codes, there's potential reduction in manual claim rework on the provider side as well. And with better and timely reassociation of EFT and ERA, providers should be seeing a reduction in AR days. The interim final rule estimated that the savings from these operating rules would be between $300 million and $3.3 billion over 10 years for providers, including hospitals and health systems and health plans. So that's a real big impact in the industry. So particularly if you're a provider, and we're going to focus on providers since we're working with the VA today, how can your organization maximize the benefits of these operating rules? And slide 18 lays out some key steps, and the VA will talk about also how they've maximized the benefits of the new standards and operating rules. But the first is, determine if your organization is conducting the transactions. If you are conducting the transactions, whether directly or through a business associate, then you do need to ensure that your systems are in compliance with the operating rules, and we have tools to help with that. Understand your agreements with your health plans and your options for payment and remittance information. Health plans are now required to offer EFT payment, so if a provider requests it, the health plan must provide it. So keep that in mind, and we have some tools, some sample letters to help providers reach out to their health plans to request payment via EFT. There's also some really important information that comes with the EFT to help you reassociate the EFT and the ERA together as a provider. And you do need to request that that information be sent to you from your financial institution, and we have some tools to help you do that as well. And finally, if you are working with a vendor, make sure your vendor has updated its system to align with the operating rules, and encourage them to become core certified to make sure that you are getting all of these benefits we've spoken about. So I'm going to take a deep breath and note that we'll now continue today's presentation with a case study from the U.S. Department of Veterans Affairs. We will first hear from Dr. Ruth Ann Phelps, who is, as Jessica mentioned, the Director of E-Business Solutions in the Chief Business Office. Ruth Ann has been with the VA for 26 years in many roles, including being the project manager for the original integrated billing software that moved VA from paper to electronic submissions of claims to third-party payers. And then we'll be hearing from Katie Knapp, who is the industry liaison of E-Business Solutions in the Chief Business Office. Katie has been working at the VA for 7 years, but has 15 years of experience in the healthcare field, focused on technical development efforts and data analysis. And finally, we'll be hearing from Susan Kirsten, who is the e-payments project manager for E-Business Solutions in the Chief Business Office. Susan has been with the VA for 22 years, with 20 of those years working with the Revenue Department. Her current position focuses on the ERA and EFT transactions, so we are very happy to have her as a presenter. Ruth Ann, welcome to you and your team, and please begin your presentation whenever you're ready.
Thank you very much for that, Erin. And if you can move to the next slide. This presentation will be a very brief discussion of how the operating rules have been helpful to VA as a provider of care. We will also share the processes that we have developed internally to maximize the streamlining provided by those operating rules for EFTs and ERAs. We will share our outreach processes and some specific examples and stories. Finally, some remaining issues will be identified where we think additional refinement would be helpful. Next slide, please. E-Business Solutions is a rather small office in VHA which is responsible for designing, building, and maintaining the internal IT architecture that mirrors the commercial industry for all the transaction processing. Next slide, please. As we all know, regulations dictate industry practice with a goal of moving the whole industry toward administrative simplification and consistency. The role that CAQH Core plays is critical in moving the industry to a more consistent platform for transactions. And as a large provider, VA benefits from this standardization. Next slide, please. VA was an early adopter of the ERA and EFT. These were the second electronic transactions that VA implemented. Thanks to our partners, PNC Bank and the U.S. Treasury, VA developed the e-payment system to replace paper checks and remittances across all 128 VA medical centers. And in 2003, began receiving ERAs and EFTs from the first of our electronic payers, Aetna. In 2004, VA was awarded the Kevin O'Brien ACH Quality Award from NACHA for nationwide implementation of VA's healthcare remittance and payment processing system, complying with HIPAA electronic standards. Next slide, please. Early in the process of programming VA software for ERAs and EFTs, a critical decision was made. That decision was to accept only the CCD plus EFTs. In 2003, when we began receiving ERAs and EFTs were not mandated under HIPAA, and therefore no specific standard was established for EFTs. Payers offered both CTX and CCD plus EFTs. Our decision at that time was to utilize only CCD plus EFTs because of the ability to reassociate the EFT and the ERA. However, this decision limited the payers to which we could connect. Looking back, however, it was a fortuitous decision, as the CCD plus was eventually specifically named as the standard. In 2003, when the ERA and EFT transactions were first implemented, the volume was rather low. But as the rest of the industry began implementing the ERA transaction, the volume of payers continued to grow. In subsequent years, VA experienced great success with the ERAs, but one of the greatest struggles since 2003, until the operating rules were published, was barriers that we faced with the EFT. Until the adoption of the CCD plus transaction, as specified in the operating rules, VA continued to have challenges partnering with payers for electronic payments. With the adoption of CCD plus and the subsequent EFT mandate, VA developed an internal proactive industry outreach strategy to help us expand our electronic footprint. Next slide, please. And now I'll turn this over to Katie to talk about our internal processes and some of the successes we've had because of that.
Thank you, Ruth Ann, and good afternoon. VA maintains an ongoing outreach initiative to expand the electronic footprint and respond to changes in the industry. Outreach is initiated to payers typically for 3 different scenarios. First, VA proactively measures payer preparedness when there is a significant shift in the industry approaching. Second, when a payer is not electronically connected with a VA for a transaction standard. And third, in an instance where a specific issue is identified requiring resolution. Next slide. In the next few slides, I will detail the approach VA uses to address the outreach scenarios, outlining the process and benefits of each. In the proactive outreach approach, VA is assessing industry readiness across payers and trading partners. The escalation approach provides written communication detailing a specific issue to payers and other applicable entities. Expanding and stabilizing electronic connections are used to expand our electronic footprint, working to establish electronic connection with payers where appropriate. And finally, resolution and compliance, the ultimate goal of the outreach effort. Next slide. VA adopted the practice of proactively reaching out to payers early in the revenue cycle transition from paper to electronic transmissions. This effort provides eBusiness Solution with a general understanding of payer preparedness and identifies payers that the teams need to conduct further work. The first step is to establish contact. Research of the payer is conducted to obtain names and contact information. If a contact is not easily identified, we contact the CEO directly. Once communication is established, we maintain a contact listing for future efforts. At this point, we've established contacts at most of our payers. One thing to note, however, is there's usually a different contact for each transaction. For example, the contacts established for the industry eligibility transactions usually cannot help with the ERA and EFTs. Different systems, different offices, different staff. The second step is to survey payers to determine readiness. If the outreach is in advance of an industry compliance deadline, a mailing is often sent first to educate and survey readiness. VA typically will then follow up with an email or phone call to fill in outstanding questions and gaps. Once we receive responses, we compile the results and look for themes to identify if payer-specific action is warranted. Next slide. The benefits of proactive outreach are fairly straightforward. Identifying POCs early opens communication. Early engagement benefits both parties. And it provides payers with advanced opportunities to engage before upcoming transaction standard changes. Next slide. The escalation process is initiated with a subset of the payers who are not engaged in the expanding and stabilization of transactions. When we do not get a response or willingness to engage, a formal communication is sent to the CEO of the payer in question from the Director of eBusiness Solutions. The content varies, but is detailed specifically for that payer. We have seen different outcomes from the hundreds of letters we've sent over the years, but most often the first letter is answered quickly and positively. This isn't always the case. If the first letter goes unanswered or a resolution is not agreed upon, a subsequent letter is sent to the same audience. If, after both letters, the payer is still not willing or able to comply, the issue is further escalated to CMS. Next slide. Submitting a complaint to CMS is straightforward and the online portal is easy to use. It should be noted here that submissions can be anonymous. CMS has been effective while helping the VA over the years, and I want to point out a few ways that they may benefit you as well. First, when CMS is brought in, they are the facilitator with authority. It level sets all participants on what is required and expected. Second is interpretation of the law. In some instances, VA and payers interpret the law differently. CMS's role will put everyone on the same page. And in some situations, CMS has gone to their legal team for further clarification. Next slide. Listed here are the summaries of the escalation benefits. Next slide. Once communication is established, eBusiness Solutions project managers and their teams work closely and patiently with the payers. There are various scenarios of why this partnership has been pursued. First, VA wants to establish electronic connection with a new payer, or if results of the initial contact had indicated that the payer is not aware or prepared for the impending change or deadline. We work with payers through each process to get to the end goal, which is successful electronic transactions between payers and VA. Sometimes there are payer-specific enrollment processes required to establish electronic exchange. Although this is not supposed to be the case per HIPAA, we do what we need to do to expand our electronic footprint. Often this process includes a series of calls or meetings during which the eBusiness teams provide background and education on the requirements. Sometimes these calls get very detailed down to the actual required data elements and time frames. The third step is not always used, but whenever necessary, we will send and accept test transactions between the clearinghouse and payers in advance of a deadline or during an enrollment process to verify transactions prior to going into production. This has been a very active step prior to compliance dates of large implementations. Next slide. As you can see by reading the benefits of expanding and stabilization, common themes keep appearing. But probably the most important benefit realized is that contacts and communication benefit everyone. Next slide. Finally, I wanted to share a few statistics with you. First, here you'll see the cumulative number of our outreach and compliance process from 2013 to present. As you move from the payer surveys to the non-compliance letters to CMS complaints, the numbers dramatically decline. VA considers the decline a major success, attributing the payer outreach and surveys as the key factor. Next slide. And as I pass the presentation over to Susan Kirsten, our ePayments project manager, I wanted to show a more specific snapshot of our EFT statistics. These numbers are a subset from our previous summary slide. As you can see, a large number of our effort over the past 2 years has been the implementation of the EFT operating rule. The success from the outreach program was significant and resulted in over a 164% growth in the number of tax ID numbers from which VA receives EFTs. But while the initial payer outreach remains successful, noncompliance can still be an issue. And here to talk in more detail about VA's EFT work and compliance is Susan Kirsten, the ePayments project manager.
Thank you, Katie. Next slide, please. In 2003, when we first implemented the ERA and EFT transactions, our volume was low, but as the rest of the industry began implementing the ERA transaction, the volume of payers we connected to grew. Throughout the subsequent years, VA experienced great success with ERAs, but struggled with EFT volume until the operating rules were published in 2014. As the largest integrated healthcare system in the U.S., VA sent and received over 65 million healthcare transactions in 2014, meeting Congress's mandate to bill and collect for our veterans' non-service-connected healthcare needs. Nearly 800,000 EFTs were received, representing 81.5% of total VA revenue. U.S. Treasury has a nationwide goal to reach 70% EFT volumes by 2017. VA has been achieving that since July of 2014. Next slide. HIPAA rules state if an entity requests a health plan to conduct transaction as a standard transaction, the health plan must do so. As Katie previously mentioned, the VA took this very seriously. In addition to all of our outreach efforts, we engaged our financial partner and our healthcare clearinghouse to ensure they were aware of our outreach and our expectation that they would help us meet our goals and were ready to partner with us and assist us in our proactive approach. They readily partnered with us and assisted in payer education when necessary. Next slide, please. Now to mention a few of the ongoing challenges we are facing, which can be broken down into just a few major areas: enrollment, fees, and credit cards. The enrollment challenges are ongoing and vary widely. The operating rules identify a maximum set of standard elements for EFT and ERA enrollments. However, the enrollments are definitely unique for each payer. Some only accepting electronic signature, some requiring wet signature on forms, others require everything to be faxed, and still others require only online enrollments. Within these guidelines, some require basic provider information that any provider has readily available, while others require unique and proprietary codes or PINs not readily available to the provider. These are the most challenging as they require finding the correct person who know the PINs and also requires continual updates and re-enrollments as these PINs change. Needless to say, it is a challenge. However, it is one that the VA expects to conquer. Next slide, please. The second area, which is becoming more common, is fees for EFTs. The payers' healthcare clearinghouses and their banks clearly state they are willing to send EFTs in lieu of paper checks as long as the provider is willing to pay a fee for each EFT. We've typically been told these are 2 to 5% of the total of each EFT. You can imagine with an overall collection of $3.4 billion annually, 2% would be very significant. The final scenario is payers sending credit cards in lieu of EFTs, assuming this meets the requirement of the EFT mandate because they are considered electronic rather than a paper instrument or paper check. These credit cards prevent the providers from realizing the benefits of administrative simplifications as it burdens the provider with additional manual processes to process the credit card payments. In addition to the manual processes, each credit card charges the provider a fee to use it, similar to the EFT fees. So although the credit cards are a benefit to the payer with administrative simplification for them and thank you points as an added incentive, they are a time-consuming and costly burden to the provider. Next slide. As I wrap up, I also want to mention 2 other common scenarios encountered that need future guidance rather than interpretation. First of all, payers requiring a provider to send an electronic claim in order to send the provider an ERA and/or EFT. And secondly, payers sending ERAs and EFTs for a subset of their transactions or plans, assuming that meets compliance. The reasons we have been provided for partial implementation vary. Some payers only implement institutional and not professional. Some implement the transaction by lines of business. And others appear to implement based on dollar amount. For instance, we found one payer that only sent EFTs for payments below $10,000. Anything over $10,000 was received by paper check. Needless to say, it is an ongoing challenge to get fully implemented and realize the full benefits of administrative simplification with the electronic transactions. While we appreciate the passing of the EFT mandate and recognize the VA has clearly benefited, the VA encourages the industry to continue to refine and define the future operating rules to prevent individual payer discretion and interpretation surrounding the compliance of enrollment and what is truly an electronic transaction based on the intent of the law. Next slide, please. And finally, here is a slide that recaps the escalation process we have implemented and found successful. Hopefully this will spark ideas for others how to implement an escalation process that fits the dynamics of your organization. Thank you so much for your time.
Great, thank you so much. And this next brings us to our 3rd and final polling question of the webinar. I will read it and then I will launch the poll and we will pause for the responses. So this question, has implementation of the Phase 3 CAQH core operating rules saved your organization time and/or money? And I will launch the poll here. Please stand by. And we will pause for 15 seconds or so for you all to register your vote. Five more seconds. Okay, I will close the poll and share the results. So just under half of those who replied, 47% said they do not know. So this shows us that there's some more opportunities for learning and education. And so we're hoping that you find these sorts of education sessions helpful. And of course, always feel free to reach out to us so we can continue the dialogue. We will continue on in the webinar here. And this brings us to our Q&A session. And we have plenty of time for Q&A. And I'll turn that over to my colleague, Jessica for us.
Thank you, Drew. And since Drew did mention that there are a lot of people interested in this topic, I'd like to point out that we do have a webinar next Tuesday on the EFT ERA topic So please feel free to go to our website and register for that if you have the time to listen. And we also have a webinar on December 10th on phase 4, again, for those of you who want to learn more about that topic. But now let's start our Q&A. So please submit your questions by typing them into the questions panel on your dashboard. We do ask that you identify the type of organization you're with at the beginning of the question so we can give you a more accurate response. So we do have a few questions. The first question is for our colleagues at the VA. The question is whether you're moving completely away from using credit cards for payment. Would any of you like to take the question on that?
Oh, I think that Susan Kirsten addressed that more or less in her presentation, but I'll ask you, Susan, if you might want to add something to that, to address that question.
Sure. What I'd have to say about that is it's really never been the VA's policy to accept credit cards in lieu of checks or EFTs for third-party health insurance payments. Credit card payments incur fees for the VA, and we're actually not authorized to accept those additional fees as they will impact the overall funding and the cost of the care we provide for our veterans.
Great. Thank you so much. And now I have a question that I think is for our core colleagues. And the question is, can you update us on the CAQH core phase 3 maintenance efforts? Erin, would you like to take that?
Yeah, this is Erin Weber. It's a good question and well timed because there are actually 3 of the 5 EFT and ERA operating rules do have some component of maintenance within them. The EFT and ERA data enrollment rules include maintenance of the data set itself. The rule recognizes that over time there may be need to adjust the data collected for EFT and ERA enrollments. So CAQH Core has a task group that meets once a year to review that data set and determine if any substantive adjustments are needed. And that group is beginning its 2015 review on Tuesday next week. So if anyone from a core participating organization is interested in participating, you can email core@caqh.org to join that task group. And then I'll let Bob Bowman, another core senior manager who's on the line to help with questions, give a quick update on the enrollment, or I'm sorry, on the maintenance related to the core code combinations, which are related to the uniform use of Carson Mark's rule. Bob?
Yep, great. Thanks, Erin. And just as Erin mentioned, there are this process is an ongoing maintenance process as well for the uniform use of the Carson-Mark's rule. And what we're going through right now is actually a compliance-based review, which will launch later next week because the latest edition of the Carson-Mark's codes were just published on November 1st. So we'll be launching our CBR, our compliance-based review, next week. We're also going to be launching our annual MBR, our market-based review, on the same code sets later this year as well. So definitely some opportunities for core participating organizations to be part of the process and help us define what the code combinations will be for next year.
Thank you so much. We have another question for our VA colleagues. The question is, what metrics has the VA used to measure the benefit and the value of EFT and ERA standards?
Well, the main one that we use is one of the slides that Susan showed you, where we track the amount of revenue or the percentage of revenue that's coming in with ERA instead of paper checks. Obviously, ERAs allow the collection of money faster than processing paper checks. With the electronic transactions, both the EFT and the ERA allow reassociation a lot easier and quicker. So there are a lot of time savings, but those we have not tracked. But we do track the revenue, and it's been significant.
Thank you so much. We have another question for VA, which is great because that's why we're here. And the question is, what has been the reaction from the health plans that the VA has reached out to due to your efforts? Has there been any pushback?
I'll let Katie address that because she's front and center with our reach out efforts.
The response has been mostly positive. A lot of times it really is just an education and narrowing down to the correct contact, and CMS has been able to assist in that, partly because they're CMS, and when they contact, I think that it really encourages the payers to bring the correct people to the table. In some cases, it's been really beneficial for the payer. As I mentioned, there's been interpretation of the law issues where we saw one thing and the payer has seen something else. And talking with CMS, there's cases where the payer's interpretation was, in fact, the correct one. So it's not all bad. It's not a punishment. We haven't really gotten that feedback. Usually it is met positively, and at the end of it, we're all working towards the same goal.
I think one of the benefits we've noticed in reaching out to payers is that because we go to industry meetings, and probably most of the people on this call go to industry meetings, we tend to know what's going on and what the new requirements are. But what we discovered when we started doing our surveys is not all payers are aware of what the new rules are. And so part of what we do is really an educational initiative to make sure that the payers that we partner with are aware of what the new requirements are. And so that really goes a long way to achieving compliance with the payers.
Thank you so much. We have one more question, and I think this one goes to our colleagues here at CORE. And it's a question asking what the costs associated with implementing the Phase 3 rules. Erin, would you like to take a stab at that one?
Sure, I'll take a stab, and Bob, feel free to add. You know, the costs really vary by the organization and where your current systems are. So, you know, some folks are using pretty sophisticated systems, so the amount of adjustments needed to upgrade and be in the compliance with the operating rules is minimal. Others are using, you know, kind of older homegrown systems that might require more remediation. So it's hard to give a solid number there, but we do have a number of tools like an analysis and planning guide that'll help you do a gap analysis to identify what those system remediations are that would help you become in compliance, and then you can kind of go from there in terms of cost. Bob, do you have anything to add there?
No, that's a great question. I think that one thing that we've done for Phase 1 and also for Phase 2 was procure the services of an outside organization to help us conduct studies, ROI case studies, for entities that have gone through the voluntary force certification process and help determine what that help monetize what the implementation costs were. And just as Erin mentioned, it's quite diverse from a health plan stakeholder type to a provider stakeholder type. The requirements are quite a bit different for each type of stakeholder. But for example, a health plan, we had some costs up to $1 million to remediate multiple systems. For this example, it's a national health plan. So they have multiple systems. Many of them were very old, and many of them required a lot of remediation. So the cost was, in excess of $1 million. But other local regional health plans that had more robust systems that were not as antiquated as some didn't have that nearly as much a cost for remediation. Again, that's just for Phase 1 and 2, so it might give you an idea that the costs vary widely. And also, we will be conducting studies in the future as well for the implementation costs for Phase 3 and also for Phase 4, for that matter.
Thanks so much, Bob. So we've answered all of your questions. I'd like to leave you with a few takeaways from this presentation that hopefully sort of summarize some of the main points of today's webinar. I would like to thank our speakers, Aaron and Bob from CORE, and thank you so much our speakers from the VA, Dr. Ruth Ann Phelps, Katie Knapp, and Susan Kirsten. Thank you so much for this very informative webinar. We really appreciate it. And then I'd like to leave you with some resources. Here's access to our website and our email address, and also ways that you can become engaged with CORE if you so desire. Also the slides and also a recording of this webinar will be available in the next 24 hours if you would like to hear this again or forward it to some of your colleagues. And also please continue to join us in future webinars. Like I mentioned before, we have some good programming coming up. And then besides that, I want to thank you for your time, and I'll give you a few more minutes back to your day. Thanks for joining.